Good afternoon, everyone. We are going to continue with an exciting panel entitled Changing the Goal from Myocardial Dysfunction to Myocardial Health. The first speaker is Dr. Eliseo Vañó, who is the Medical Director of CT and MRI at Nuestra Señora del Rosario Hospital in Madrid. He is an expert in cardiovascular, spectral, and oncological imaging. He will talk about the innovation in cardiac magnetic resonance. Go ahead, Eliseo.
Thank you, Emilio. Good afternoon, everyone. Thank you, first of all, to the queen of cardio-oncology since today, Teresa Lopez, and to the organization, congratulations for the symposium. I think it's brilliant. And thank you to the audience also for, probably you are tired and hungry, so we will try to show a lot of images today. So, well, we're going to talk about the role of cardiac magnetic resonance. These are my conflicts of interest. So, left ventricular ejection fraction is the most frequently used tool, but detects only late cardiotoxicity. We know that is the tip of the iceberg. Cardiac magnetic resonance stands out for the accuracy, reproducibility, and ability to provide tissue characterization without any ionizing radiation. That's the advantage over CT. So when patients develop cardiotoxicity, the likelihood of response to heart failure treatment is greater if therapy is initiated earlier. And the changes in myocardial function can be potentially detected despite preserved ejection fraction, which can help starting cardioprotection. So, well, the ability of CMR to detect subtle changes in cardiac function and tissue composition has made a useful tool for early detection and understanding the pathophysiology of cardiotoxicity. Of course, we have already seen these new guidelines, and regarding imaging, of course, echo is the first line, but we also have that strain is global longitudinal strain is recommended in all patients with cancer if available. And regarding to CMR, to cardiac magnetic resonance, should be considered for the assessment when echo is unavailable or non-diagnostic. That's not so infrequent. And also, well, of course, we have the definitions, take into account the GLS, so it's an important factor for defining CTR-CT. And also, it's remarked that with poor image quality in echo, or when it's non-diagnostic, CMR were considered including fast sync when available. We will talk later about fast sync. So what's new with MR, about MR? 3 points, probably. 3 points can summarize the present of the new technical things in MR. Acceleration, that allows us for many different sequences. Multiparametric imaging, this is the so-called multiparametric imaging. T1 mapping, extracellular volume, T2 mapping, T2 star mapping. Probably, of course, in every multiparametric study, we also include LGE, late gadolinium enhancement, that is one of the most important sequences in cardiac MR. And the third point will be the strain, SENC and myostrain. That's one of the most important new features, new techniques. Acceleration. So we have different techniques. We will not gonna go into detail. But if I show you these images, which is shorter? Can you see the difference in quality in the images, in these CINA images? Probably is pretty difficult. But this one is almost half of the time of this second one. So, and this using compressed sense. This is a technology that is accelerating not only CMR sequences, but also sequences in all kinds of MR, and this is a change. We are making MR similar to CT in acquisition times in some explorations, some examinations. And this thing goes even more complicated when you use smart speed, another new technology that uses artificial intelligence in different phases for accelerating even more the images. And this is the endpoint, the clinical application. This is the group of Borja Ibáñez in CENIC, and this is amazing. This is a complete cardiac CMR protocol in 11 minutes with post-contrast evaluation with LGE, late gadolinium evaluation. And this is by the accelerating techniques. So we acquire, or they acquire a three-dimensional cine sequence, ESOS, and then a three-dimensional gadolinium enhancement. Just one breath hold and one breath hold. So the rest of the time is localization. This is, at least this second part, the late gadolinium enhancement is available in many sites. This is not so frequent to have it available in other MR equipments, but we are, for example, using this routinely in our workflow. So it's a very important advantage, this accelerating in times. And this is multiparametric CMR. There are three components, images based in T1 mapping, T2 mapping, and T2 star mapping. That we do not use this one in cardio-oncology normally, but we do use T1 mapping routinely for quantifying fibrosis and extracellular volume. In this second one, we need to acquire pre and post contrast. For quantifying extracellular volume, ideally, we should have also hematocrit. T2 mapping quantifies edema. I say quantify because we get a millisecond, so we have an exact number, but the problem with T1 mapping and T2 mapping is that they are different between each equipment, each MR scanner. Even the same model from the same manufacturer may have different values in different hospitals because of differences in the magnetic field. So you have to validate your normal ranges before using this clinically. And this is also another paper by Borja Ibáñez and CENIC group that says that among CMR multiparametric evaluation, of course, T2 mapping is the first, is the earliest marker. So it normally means intracardiomyocyte vocalization, and at this point where T1 mapping is normal, if you halt anthracycline treatment, you have a complete normalization. So you can prevent cardiotoxicity, but if you continue without any cardioprotection management or without any other intervention, you will have irreversible stage with fibrosis and even scarring and cardiomyocyte loss. And these are the classical three kinds of myocardial fibrosis that we can study with CMR. Basically, we have one of them, it's the infiltrative interstitial fibrosis in amyloidosis typically, and we detect it with both techniques, T1 mapping and late gadolinium enhancement. We have the classical fibrosis that is a scar or scar fibrosis, the replacement fibrosis that is irreversible normally, and we can also detect it with T1 mapping, but it's classically detected with the LGE, the delayed enhancement, late gadolinium enhancement sequences. And this one is interesting because it may be potentially reversible. It's reactive interstitial fibrosis, and we detect it with T1 mapping. So these are the multiparametric tools that we have to examine the cardio-oncology patients. Of course, fibrosis means prognosis in these patients. But this is not the only point. CMR in cardiotoxicity can range in different several pathologies. You can see the different ventricular volumes and ejection fraction evaluations where normally GLS is recommended if available. And if the change is less than 10% in LVEF, may be difficult to detect. RV is frequently affected and probably overlooked. Left ventricular masses with the famous Green syndrome, the inflammatory cardiomyopathy with immune checkpoint inhibitors, amyloid deposition, and myocardial fibrosis. But I would like to remark that LGE is a late event. So it's ideal to use T1 mapping, extracellular volume, or even other tools, as we will see. So, well, this would be a conventional cardio-oncology CMR protocol. So, scouts about 5 minutes, that's one of the longest part, localizing the myocardium and getting the best cardiac short axis, long axis. Cine SSFP, so this is the classical, cine acquisitions in different planes, short axis, long axis, stereo images. These are for detecting edema. and they cannot quantify it, just detect it. So sometimes they are not so useful for follow-up. And then multi-parametric evaluation, T1 mapping and T2 mapping, those are normally pretty, not very long, that's 1 slice per breath hold. And then we normally use contrast, perfusion imaging, and these images for quantifying better the ventricular, the LVEF. And we finish with the LGE that probably, sorry, LGE is probably the most important sequence classically in CMR, and now we can acquire it in a single breath hold with a very good quality in 3 dimensions. So probably you could reach a high quality study in 45 minutes door to door, but normally the schedule is 1 hour. So that's a problem for availability of CMR in the clinical workflow. That's a huge problem. We cannot do CMR to all cardio-oncology patients. So now comes the third element, the strain. Maybe it's going to help us a lot. All of you know that it's a measure of myocardial deformation, a relative change in length, and has 3 components: the shortening in longitudinal and circumferential dimensions, negative strain, the thickening and lengthening in the radial direction, the positive strain, and the torsion of the myocardium. The ranges normally are accepted that less than -17 is normal. So what may be the usefulness? The situation, the most common situation, will be the heart failure with preserved ejection fraction. It's well described and it's pretty frequent. LVEF, we know that it's strongly influenced by compensatory mechanism. It's not so reproducible as we thought. GLS, the global longitudinal strain, but not the ejection fraction, was an independent predictor of mortality in patients with preserved, intermediate, and reduced LVEF. In heart failure, its 1% increase in GLS was associated with a 5% decrease in mortality. We already had trials with GLS-guided management that had a significant lower reduction in LVEF 1-year follow-up in cancer patients. And using the 15% cutoff in GLS reduction is recommended when monitoring cancer therapy according to the new guidelines. So low LVEF is a good, then in that situation, LVEF is acceptable prognostic factor, but if you have near normal left ventricular ejection fraction, the strain is a better prognosis factor. So how we measure strain? We have 2 techniques, echo and cardiac MR. Classically in echo, have some reproducibility problems, of course, it's operator variability. And in CMR, the classic ways were tagging these images, probably all of you have seen sometimes with this kind of grid that are saturation bands, feature tracking that uses conventional cine to trace the movement of the myocardium, and SENC. This is the new one, the new strain-encoded sequence that really encodes the strain in MR, and this has the lowest variability. So feature tracking, that was probably the most used because of it's kind of free. You only have to use your already acquired cine images to trace the contours and estimate the GLS, the GCS, etc. And you can make polar maps, so this is at least available. But what about SENC? SENC is the best way to measure strain with MR. It stands for strain encoded, and you apply tags as a series of planes in the through plane direction. It's a parallel planes that you apply, and as the myocardium contracts, the plane in the through plane direction compress, and that causes a shift in the location of the peak spectrum in that famous K space that we use with radiologists sometimes talk about, and the rate of that shift can be used to determine the myocardial strain. It's not so complex at the end of the day, but we get a couple of images that are tuned to the high or a low frequency peak to create an image that represents systolic or diastolic strain. So you have the low tuning and the high tuning images. And we make a composite, and then with that composite is what we work with. We are going to show it in a few seconds. If we compare it to echo, of course, we can detect earlier the dysfunction. It's a very short exam. That's an important point because in 10 minutes we can finish the strain, this SENC protocol. It's consistent, and you can compare between different equipments. You will always have the same values. That's a very good point. What do we need to acquire MyoStrain and Senk? First of all, an MR scanner. The only problem is that right now had to be Philips or United, only these two manufacturers. In a few months, probably will be available for rest of manufacturers. You need a sequence that is called FastSync, right now by Philips or United. And the third element is the MyoStrain software by Myocardial Solutions for the post-processing. And also you have to complete a certification training that normally lasts for 2 days, a couple of days. We started in September last year, so 1 year of experience. That was 2 days of on-site training with 30 volunteers. That was really easy. And in the first scans, we could complete them in less than 15 minutes and make an on-the-fly post-processing in 5 minutes, not by medical doctors, not by radiologists or cardiologists, but our 3D lab that is composed by technicians, by radiology technicians. So this is the protocol acquisition. You can see that the magnet time, real magnet time is 1 minute. So it at the end is 10 to 15 minutes door-to-door protocol, including all the positioning. Of course, we don't use gadolinium for this protocol. It's one apnea scene locator that have this quality. So they have acceptable quality, so you can quantify even the conventional LVEF, and you get the 1-bit fast sync acquisitions, so six breath holds, and you have completed all the acquisition. Sorry, I don't know why it's not working the scene. You will see it. So it's a really simple and fast protocol, as you can see. So how we process MyoStrain? Those are the images that we get when we finish that composite images with these color-coded images. So we analyze the contours in systole, and the software automatically traces the contours. We only make sure that they are correct, and we only have to analyze 6 images for quantifying the strain. So it's really fast and can be done by a technician. And this is the report. It's a very easy to understand report. We have some important points. One, MyoHealth score that is based on the percentage of normal segments. So MyoHealth stands for segment with circumferential and longitudinal strain less than -17, and among all the segments. And there is also an important point that we have also conventional strain measurements and traditional measurements. So with this exam, we have all the measurements in a single examination in 10 minutes. What are the possible applications? They are really extensive: asymptomatic patients, symptomatic patients, or today, cardiotoxicity, cardio-oncology patients, and also for cancer survivors. So, but the applications are really extensive. Even for, as we will see, for chest pain in other patients or in cardio-oncology patients, because we can detect myocardial ischemia, as we will see. So there are some papers that talk about this risk stratification of heart failure patients, not only in cardio-oncology, and this is the concept that we can reach with this MyoStrain. With ejection fraction, with echo, the ejection fraction drops very late, and with MyoHealth, we get an earlier detection of this dysfunction earlier, so we have this additional diagnostic window for preventive treatment. That's the subclinical disease detection with this technique. Of course, this changes the mortality, so we can detect subclinical dysfunction. Beatriz probably will talk you later a little bit about this trial, the PREFECT trial, that shows the utility in cardio-oncology. So how can we detect earlier than ejection fraction in this patient? And the most important thing, it's fast and it's reproducible. And even in the data of that trial, we can see that maybe even earlier, the MyoHealth earlier than T2 mapping and T1 mapping. So even is earlier than multiparametric imaging. Of course, earlier than echo and ejection fraction and GLS. This is the other study that is active but not recruiting, so we are waiting for the results, but very interesting PROACT trial. It has a good correlation with late gadolinium enhancement, so we even can use these strain images to anticipate where we're going to have some fibrosis. And this is the ischemia detection that we talked about. You only have to hyperventilate the patient. You don't need to use adenosine or regadenosone. You only hyperventilate for 1 minute. This is very easy to perform in a clinical routine workflow. And then in the breath hold, you get a reactive vasodilation, and you get these subtle changes, how you can detect ischemia in this patient, in this infralateral wall. And this is the typical clinical case where we have an ejection fraction near normal, 51%, with a normal T1 mapping for in 3 Tesla scanner here, normal late gadolinium enhancement. This is an almost normal patient. But when we acquire myostrain, we get this myo health of 35 that is clearly pathologic, is not normal. Below 70 is not normal and can have prognosis implications. So we can stratify patients and find which patient will need cardioprotective management. What could be the future? The future probably uses more than images, more than biomarkers or genetic or analytic biomarkers. Probably gadgets in the ECG, in the cardiac monitorization, probably, of course, other data, clinical history, etc. Of course, we'll go through artificial intelligence, machine learning, big data, and radiomics, is extracting features from the images and using them. Of course, with a cardio-oncology, a good cardio-oncology team in your hospital, that everything passes for having a good team. And probably we will reach an early detection, understand the pathophysiology, prognosis, and the tailored treatment. Take-home messages. If we rely solely on the ejection fraction for detecting cardiotoxicity, we will be late. CMR stands out for its accuracy, reproducibility, and ability to provide tissue characterization without any ionizing radiation. The ability of CMR to detect subtle changes in cardiac function and tissue composition has made it a useful tool for early detection of cardiotoxicity and also for the management of cancer survivors. Earliest alteration in MR may be a strain at least as early as T2 mapping, then T1 mapping, and then LVEF. Strain-guided management is optimal. Senk and myostrain have proven to be robust for measuring a strain with acquisition time about 10 to 15 minutes, potentially mitigating availability and cost concerns, evaluating cardiotoxicity with CMR. That was the main problem until now. So it opens the possibility of early detection, accurate stratification and follow-up, and therefore a personalized cardioprotective treatment impacting prognosis. And these new guidelines on cardio-oncology recognize the importance of CMR and SENK to facilitate early diagnosis and management of cardiotoxicity. Thank you very much.
Thank you, Eliseo.
Okay, we move to the next speaker because we're running a bit late. So next speaker is Dr. Beatriz López Melgar. She's a cardiologist in Hospital de la Princesa. She has a broad experience both in research and also in daily clinical management of patients.
Thank you, Silvia. Thank you, Emilio, for your introduction. And first of all, I want to thank Teresa and all the CardioTox organizers for this invitation. It's really an honor to be here among these experts in the cardio-oncology field. And this is what I have to start my presentation with my disclosures. I'm not an expert in cardio-oncology, so I'm just a general cardiologist in love with cardiovascular risk and cardiovascular risk factors, working with preventive cardiology for more or less 10 years. Also, I have been working with imaging techniques, all modalities, for more than 12 years, and 8 of them dedicated to research in image-based biomarkers on atherosclerosis for cardiovascular disease risk prevention in the National Cardiovascular Research Center here in Madrid. So I don't know why, maybe due to my research background or just by chance, 9 months ago I was presented this new solution, the myocardial solution, And I feel very curious about the potential of this technique. So I decided to start working with it. And today I have been asked to bring you my experience, and I will try to show you how I see this technique in our patients, the patients that are referenced for a conventional cardiovascular magnetic resonance in our daily clinical practice. So I will present you 3 clinical cases. But first of all, I wonder for the first time why this myocardial strain is important. Because alteration in the myocardial strain precede all changes. And I reached this conclusion after reviewing all the literature, a lot of the literature that Eliseo already presented to you. And also my idea was reinforced when I saw this review written by very well-renowned experts in cardiovascular imaging that conclude the changes in the deposition of collagen at the myocardium, together with detection of alteration in the strains, are the earliest alterations that we can find when we study the continuum of heart failure and myocardial disease. So, and why can myocardial strain have a potential clinical impact? You just need to look at recent guidelines on the management and treatment of heart failure. They have expanded focus for the first time in their recommendations to look at healthy individuals that are at risk for heart failure. Who are these individuals? These individuals are already endorsed in these guidelines and are patients that are very often seen in the cardiology department, but also in the general practitioners. No? Those patients with cardiovascular risk factors, hypertension, diabetes, obesity, both asymptomatic and those who have already developed a clinical event. But also these patients are those that are exposed to cardiotoxins. This is the issue that we are treating today. And also these patients can be those with a family history of cardiomyopathy. So as you can see, true potential and guidelines are focusing for the first time in risk stratification in the population. So I decided to start using MyoStrain, the fast protocol, this 10-minute protocol that Eliseo Vañó showed you, in asymptomatic patients mainly, but also I add a MyoStrain to conventional CMR in those patients that were symptomatic or were already diseased patients. And this is the first case that I want to share with you. This is a young man, 45 years old, very sporty with dyslipidemia and stage 1 hypertension and psoriasis, that you all know that this is a cardiovascular risk factor also. So he came to the cardiology department just to check up and see if he can continue with his training and with his sports. No? So he underwent a clinical interview and an EKG that was normal, then a cardiac ultrasound that revealed borderline left ventricular enlargement. So he was referred for a cardiac MR that confirmed this mild dilatation of the left and right ventricles, but the rest of the parameters were normal, no leg gadolinium enhancement, normal mappings. So the cardiologist asked for a treadmill test and another test, but at this moment, with all these tests normal, we still don't know if these are just adaptive changes of an athlete's heart or something is abnormal in this individual. So the cardiologist asked me, and I proposed to do a MyoStrain. And this is the fast CINE protocol that I do together with the MyoStrain to plan the acquisitions. And you can see that there is a mild enlargement of both the left ventricle and right ventricle. No hypertrophy, and This is the myostrain images of the patient, and as you can see, the strain, the deformation is encoded in color, so you see blues. This is good strain. And this patient had a report of a very normal strain of the myocardium, and the myo health score that Eliseo also presented was 100%. So you can tell this patient that this is normal. This is just an adaptive change of his heart, of his heartless heart. And also, to me, this case is representative not only for heartless heart, but also for those patients that are at risk of heart failure. And those patients that I mentioned with hypertension, diabetes, etc., in which looking beyond, maybe we can do myostrain as a first line test, because we can speed up the diagnosis, and we can avoid unnecessary tests, and also you can avoid delaying treatments if the patient really needs them. And as you can see, this patient is a very huge spectrum. We are talking about a population level, but because we are talking about cardiovascular risk factors, so this test that is fast and simple and don't need contrast can be implemented quite easily here. No? Regarding the prognostic value of strain in the population, there is a very recent publication from the MESA study. You may know MESA study because it's the cornerstone study that demonstrates the value of coronary artery calcium score to predict cardiovascular disease. So in this population-based study, they did the analysis of a strain in 1,500 participants, and they showed that to have a reduced intramyocardial strain, the one that we measure with myostrain, indicate poor prognosis, increased risk of not only heart failure, but also minor cardiovascular events and cardiovascular death. So yes, strain values may have a prognostic impact when you study them at a population level. And also something that you have been discussing during the morning, how can we assess cardiovascular risk in cancer survivors thanks to a strain? And because cancer survivors, cancer treatment is a new, well-recognized cardiovascular risk factor. In this study, a population-based study, the ARIC, that is focused on primary prevention, they show that to receive cancer treatment is an independent cardiovascular risk factor that predicts major events irrespective of conventional risk factors. So this is an issue that is increasing due to the improvement in cancer therapy. So these patients are the prevalence of these patients are increasing, and maybe this kind of protocols can capture and identify early these patients to be treated early. And this is the second case. This is a young man, 34 years old. He was volunteer for myostrain test, and we found that he had a very poor performance of the myocardial function, despite he had normal ejection fraction and mild dilatation of the left and right ventricle. So in this case, I have to reconstruct all the history from the scratch. So you can see here the images, how the patient is full of yellow spots in the circumferential evaluation, in the short axis and in the long axis evaluation. So I did a fast clinical interview that didn't come up with any conventional risk factors. The EKG had unspecific alterations. Cardiac ultrasounds were normal, except for this mild dilatation of the ventricles. The thrust test was normal. The Holter was normal. So something was missing because the strain is very sensitive. The positive predictive value is very high. So I decided to start all over again and did a very dedicated clinical interview. And then the patient recognized that he had not quite well habits, and He had a consumption of alcohol and other drugs, and also he was practicing very explosive training in CrossFit, you know CrossFit. Well, so I recommend him to stop this sport practice and improve the lifestyle and repeat the myostrain 3 months later. And this is what we find. All blue appear again. And this is the report. He almost doubled the myo health index in 3 months thanks to these lifestyle changes. No? This is the kind of cardiotoxicity due to drugs and bad habits, and also probably exercise-induced cardiac fatigue. But to me, this is like a patient that is exposed to any agent or therapy that is cardiotoxic. Like here, I see that myostrain can be a first-line test to detect early myocardial impairment, and also very important to monitor the improvement, the changes with treatment, thanks to the robustness and the low variability of the test. And regarding the cardio-oncology, this is the main study that Eliseo also presented to you, the Perfecta study. Basically, this is a study that compared the diagnostic performance of different biomarkers to detect cardiotoxicity. And they show that basal strain measurement before treatment could predict the occurrence of clinical cardiotoxicity more accurately than ejection fraction and other biomarkers. You have here the sensitivity and specificity of the rest of the biomarkers, including troponins and brain natriuretic peptide. And also what is also important to me is to find that this strain evaluation can predict the reversibility of the myocardial damage. In patients that go below 50% of this myocardial health, the probability of recovery was very low if you let these patients reach to that point. So next case and last case is young man, 47 years old, asymptomatic, with alterations in the EKG. He had negative T waves, but very subtle in the EKG. So the cardiologist asked for a cardiac ultrasound that was normal, advanced cardiac MR, everything normal, and a Holter treatment test. Can it be a normal variant on the EKG, or maybe it is a subtle cardiomyopathy? So I tell this cardiologist why not to do a myostrain, and this is what we found. This is the cine images, as you can see. There was a very mild hypertrophy in the basal septum, 12 millimeters, but maybe here in the apical lateral and in the apical inferior and inferior basal, there are some alteration, but when you measure this thickness, everything was normal. So we did a myostrain and confirm that, look at here, the apex was contracting with abnormalities. Here, you see. And also in the basal septum, when we already saw mild hypertrophy. So I tell this, his referral cardiologist that this is not normal, and despite the rest of the tests were normal, and probably it's an early finding of an apical hypertrophic cardiomyopathy. There is no need to do nothing right now, but we need to follow up this patient. And for example, here in the screening of primary cardiomyopathies, not only hypertrophic, but also other cardiomyopathies, myostrain also can be a first-line test to avoid all unnecessary tests and to speed up the diagnosis. And this study also present the value of a strain in the differential diagnosis of left ventricular hypertrophy. And I want to point out here something that is very interesting, is that how these strain patterns are different depending on the cardiac disease that we are facing. I truly think that with experience, we will be able to read patterns in the alteration of strain the same way that now we read patterns with late gadolinium enhancement to make the differential diagnosis without contrast. But we need more experience in this. So for summarizing, I think the evaluation of myocardial strain to evaluate cardiac function has huge potential with multiple applications for early detection of diseases and prevention of heart failures. And all the indicators that I presented are aligned with the directions that are currently recommended in the guidelines. Of course, we need more prognostic, more studies to determine the prognostic value of this technique. But I think it's a good technique to screen population, and it can improve our current standard of care. So thank you for your attention.
Okay, thank you very much, both of you. We don't have a lot of time, but we have time, I think, for a couple of questions, if somebody wants to ask something. Well, I'd like to make a comment. Well, according to the data, the publications, I think what you, among all the things you commented on CMR, the most interesting or the most innovative is the use of myostrain. And it looks like the reproducibility is just amazing, which is like central for its use in cardio-oncology because of the longitudinal follow-up of the patients. And it looks like a very robust technique and very, very sensitive. So the big question is probably what to do with this information. It's a very sensitive technique, but for the moment we don't really have much information. So what could you do with this patient if you, for example, find a cardio-oncology patient with a low myostrain or low myocardial health?
Oh, thank you. Yes, indeed. Well, we are happy because we are overcoming the big issue of echo. We are relying on this recommendation in this new guideline in an ejection fraction that most of you probably do in 2D, despite it is recommended to do it in 3D. Not much people use strain, but we are overcoming a situation that can project us in a better future, I think. And this is the first comment. And the second comment, we don't have still a very cutoff value because we all like cutoff value to make decisions. But maybe we can start doing this using the reference of cutoff values that we have for echo, and of course make a huge effort to implement randomized controlled clinical trials. That's what we need now for the strain, and to see the true improvement in prognosis. That is the question that we all wonder. No? We don't want to do a lot of fancy things. We want to do just the right thing to make the right decision. And I think I think there is no need to stop using this because we have a very huge background with the strain with echo. Now we are having a better technique that's at least so the strain better, and then continue working in doing research to set up these kind of values for the general public.
Yeah, and I think an important message is also that these are different technologies, different sequences, and the 15%, for example, for echo is not applicable here. I mean, we need our own threshold for this technology.
For sure. Maybe it can be less or lower.
Yeah. Any question for the audience?
Alexander. The microphone.
Thank you. Thank you for those two great presentations. First comment is I'm very excited about this. Not not criticisms of the guideline, but one of the things we're aware of is I suspect there's going to need to be more monitoring. And it's a real challenge to echo services to be able to deliver the increased demand. I hear different statistics. 15% of all echo is now in cancer patients, and with the aging population, it's going to get greater. And what we also know is the majority of patients are actually going to be okay. So cardiotoxicity is always in the minority. And so what we need is good tools that are highly sensitive that can actually reassure that everything's normal. So I think the biggest advantage of MyoStrain is actually going to be the negative predictive value of reassuring people on cardiotoxic treatments that they can stay on them safely. And then if a change does occur, it's a little bit like what happens if a biomarker rises. We need closer monitoring, then there's a clinical decision. Some patients may need treatment, but not everybody. And we can just have a closer monitoring. So I think this technology is going to become a new part of the armamentarium of modern cardiology and cardio-oncology.
Thank you for your great presentation. I fully agree with what Alex said, and I also want to add that regarding the threshold, the change in the GLS during therapy, I think that there is still a lot of controversy, and in fact, we spent a lot of time discussing at the guidelines meeting if 15% is the right threshold to consider asymptomatic mild CTR-CD. But I think that for the beginning, we need to use the same threshold also for cardiac MRI, because we are not speaking about absolute value, but we are speaking about how this measurement changed during the cancer process. And another great advance of this technique, I think, it could be to use in cancer survivors, because we have a huge population of cancer survivors at risk of heart failure or at risk of ischemic heart disease. And if we really have a good technique, a sensitive technique to rule out these problems, maybe we can simplify the long-term follow-up of these patients.
Yeah, I totally agree, Teresa. And we have talked about this several times, that if you can just discharge patients, they go back to the non-diseased population, so you don't have to do an echo 5 years afterwards, which if the patient is 30, is 40 or 50 years, every 5 years. So it's a lot of work and a lot of echoes.
Yeah, I have a short question for both of you. Do you think that MyoStrain is feasible in the routinary busy workflow in an imaging department?
At least in my opinion, it may be feasible because it's 10 minutes, 10-minute exam, and you can schedule patients. It's frequent that maybe an oncologic patient has, of course, a CT scan in all the visits, but sometimes they also have, for example, the breast cancer patient have an MR of the brain, and that would be probably inside the magnet 7 minutes or so longer exam if you want to add a MyoStrain in those patients. And if they don't have an MR scheduled for other reason, 10 minutes MR is probably feasible. So it's just to organize yourself and to try to get the best experience to be very efficient. And I at least I consider it could be feasible in the clinical workflow, routinary workflow.
Okay. We need only Philips MR scan.
Well, that's
or
United, that is a Chinese
imaging.
manufacturer. Right now, today, yes, only those manufacturers, but as far as I know, they are working hard for extending the sequence to all vendors, to Siemens, GE, Canon, etc. So I hope probably next year will be available in the rest of the vendors.
We have Philips MR scan.
You're lucky in that aspect.
Okay, last question for Dr. Farmakis.
Yes, thank you very much. Excellent presentations. We're all very excited about this new technology. It seems to be very reproducible, not so not dependent by the imager, and so on. Very quick, 10 minutes and you're done. No need for contrast or anything. So many advantages, and I will echo what Teresa said earlier, that it is a perfect rule-out tool for the long-term survivorship programs. And also I would add to this also the fact that we were discussing earlier, for example, when to stop cardioactive medications, and we were all saying that we don't know according to the history. But that would be a good, for example, a good way to look at the patients and see that is everything normal or back to normal, then you're very safe probably to discontinue the medications. One potential application among many others.
For sure, today I think the preserved ejection fraction is not as equal to normal cardiac function, and this is the tool that we can differentiate between both situations if you want to stop a medication, a preventive cardiology medication, or continue with until the strain is normalized, for example. That's a good application.
Okay, I'm sorry this discussion is so interesting, but you need to have lunch and we need to finish the discussion. So before we close the table, I would like to thank Myocardial Solutions for providing us with this excellent technology, and second for supporting us in the organization of this type of courses and congresses and so on. Thank you.